Simple daily tasks, like pouring a glass of water or grabbing and holding an object, are done so routinely that many of us take our ability to do them for granted. But do you know people, or do you have patients who struggle with these tasks? Hi everyone, my name is Clemens Müller, and I would like to welcome you to the webinar, How Advanced Technology Can Help You Overcome Challenges in Arm Rehabilitation. If you have any question during the webinar, please use the chat function on the right side. We will try to answer during the Q&A session at the end of the webinar. Or, if it's directly related to our guest speakers, we will take up your question during their presence. Today, we know that approximately 50% of stroke sufferers also have arm or hand impairments. This could range from a complete loss of motor function to limitations of specific functions. Even basic activities like showering, getting dressed, eating or preparing food, going to the bathroom, transferring in everyday life, or simply participating in society can be exhausting or impossible. Not being able to carry out these tasks dramatically influences the amount of independence each patient can maintain. Moreover, these limitations also hinder therapy itself. It's difficult for the patient to move his arm or hand at all, much less repeatedly, especially in the early phase of rehabilitation, when we know there's a high potential of regaining functions. Stroke is a very common neurological disease. Globally, 1 out of 6 people will have a stroke in their lifetime. In the US, someone has a stroke every 40 seconds. We have seen a continuous and dramatic increase in stroke survivors, and we expect this trend to continue in the future, resulting in much higher numbers of stroke patients. Not to mention the great number of other neurological diseases which also can affect arm and hand function. The increasing number of neurological patients in the future can be attributed to the demographical shift, as you can see as an example from the US. Frankly put, society is aging, and the higher density of elderly in the population will lead to higher numbers of neurological patients. This shift will lead to higher healthcare costs and more hospitalizations. We expect the number of hospital admissions to nearly double by 2050. From a rehabilitation point of view, the main challenge will be a lack of OT resources to handle this increased number of neurological patients effectively, especially in consideration of the increased healthcare costs. However, lack of resources will not be the only challenge. Requests for individualized therapies will further burden caregivers and clinics. Patients vary widely in terms of their severity, functional impairments, and time since incidents. Your job is to provide the best therapy solution according to the needs of the patient. Basically, you have to individualize the rehabilitation through therapy composition and constant shaping. From motor learning principles, there are some key factors which influence a successful recovery of a patient. And I am pretty sure you'd agree that therapy needs to be intensive, active, and challenging for optimal recovery to take place. Therapy should start early, focus on practicing functional tasks used in daily life, and include a high amount of variability. Motivation is very important for adhering to intensify therapy and leads to improved training outcomes. And information and feedback can influence learning in a positive way. But are such key factors optimally integrated in existing therapy models? Video, please. For most patients, it's quite difficult to use their arm or hand to perform specific tasks with a high number of repetitions during the early phase of recovery. The patient tires easily or makes compensated unphysiological movements to carry out these tasks. Thus, intensive and functional training is rather complicated. These aspects also have a direct impact on the patient being under or over-challenged. Furthermore, high frustration can negatively influence patients' motivation. So, what does a typical day in the life of a patient look like in rehabilitation? Generally, the patient sleeps for 8 hours, right? And the latest research suggests that top clinics offer around 3 hours of different therapies, including physical, occupational, and/or speech therapy for stroke patients. In comparison, other studies showed that in different regions, the amount of actual therapy can be less than 30 minutes a day. So, even in good hospitals, patients are inactive for around 90% of their time. In other clinics, even more. How can we incorporate the previously described key factors for successful recovery, like intensive and challenging therapy, given the existing conditions? Especially if we know that increasing the number of task repetitions in animals and humans results in cortical changes and functional improvements. Evidence from animal studies suggests that the minimum of 400 to 600 repetitions is necessary to lead to structural neuronal changes for the upper limb. If one compares these numbers with what's offered currently in rehabilitation therapy, there's a large discrepancy. Although results from animal studies might not be directly applicable to humans. The studies suggest optimal neuronal or reorganization and functional recovery require a higher number of repetitions. After showing you certain challenges you might face or will face in your daily clinical routine, like rather low number of repetitions and levels of intensity according to motor learning principles, difficulty in providing individualized therapy in terms of shaping and composition, and an increased number of patients which might give rise to a resource issue. Today, I want to give you insights into solutions which should help you overcome these existing challenges in neurorehabilitation, and which are based on experience from clinicians who will share their way of working in the comprehensive field of upper extremity treatment. So, today's main lesson will be how to provide the most efficient and effective arm rehabilitation for your patients. Therefore, I would like to introduce our first guest speaker, Dr. Nick Ward, a consultant neurologist at National Hospital of Neurology and Neurosurgery, and a reader in clinical neurology at UCL Institute of Neurology, London. He published more than 100 articles in peer-reviewed journals in the field of neurology, and you will find more than 6,000 citations about him in the research community. If you have any questions for Nick, please use the chat function on the right side. Nick will try to answer some of the questions directly. Hello, Nick. How are you?
Hello. Good to see you.
Nice to see you again. We've heard that the intensity level of current treatment is rather low. Does this align with your experience? And if so, how can we solve such an issue?
So I think that's right. I think most people in the field now think that the amount of upper limb therapy that's offered to patients is quite low. And I think you can think about this in a number of ways. You can look at the acute setting And you can say, well, one of the problems here is that patients are too sick to undergo rehabilitation strategies. We have evidence from the AVERT study, which is putting people off intervening with rehabilitation strategies quite early. The priority in an acute setting is to get people into their own home environments, both for patients who want to go home and for hospitals who want to discharge them. And as a consequence, most of the focus tends to be on gait and balance and transferring. So you can kind of see how upper limb doesn't really get much of a look in the acute setting. When patients are transferred home, I think the dose of upper limb rehab that people receive is probably also quite low. And again, there's a number of reasons why that might be. I think there's generally a nihilistic view about how well arms do. I think there's an idea that arms don't do very well. So if they're not going to do well, then why should we treat them? We should concentrate resources elsewhere.
Okay.
I think arms is complicated. I think people run into problems with shoulders, an increase in tone. And I think these problems extend into the chronic period when there's very little expectation that arms will improve very much, and consequently they don't really get treated. So I would agree that the dose, if we're looking in terms of number of hours of therapy, is probably too low to make a difference.
Okay, and which role does technology play maybe to overcome such an obstacle of this low dosage? What do you think?
So, I mean, we have to think about ways that we're going to get our patients to do more. So, one way of thinking about that is having more therapists. Now, that's probably unlikely in current healthcare settings. And any way that we can get patients to do more is likely to be beneficial. And so I think technology enters into it that way. Of course, technology has different benefits. One of the reasons that we find that patients don't carry on with their training, with their exercises, because they find it boring. So being able to motivate people, encouraging them to take part, to do mass practice.
What do you mean with motivation? Do you mean motivation they are able to do the movement by themselves, or to feel again the movement, or is it because it's a new approach, a technology to train with a new technology?
So that's a good point. So one thing might be that they just enjoy doing it. So that might be the use of technology might incorporate games that people might find motivating. They might find them stimulating. Ultimately, we want to search out games that people feel immersed in, so they don't feel that they're actually doing rehabilitation. So I think that's one important point. I think the second important point that you bring up there is that they're asked to do a task that they can do. So, for example, various robotic technologies would provide the theoretical advantage of weight support. So, for example, we know that if the shoulder is weak, the post-stroke arm is very heavy, but you do give people the opportunity to work on their ability to control reaching movements, for example, if you take out the effect of gravity in the arm. So that has some benefits as well.
Okay, and you are also using technologies in your clinic or in your environment. Can you give us an insight into your approach? What do you do special compared maybe let's say a conventional approach to do upper arm rehabilitation? Is there something specific you are doing?
So at Queen Square, what we were seeing in our clinics was the same thing that we've just talked about. There was a lack of rehabilitation strategies for the upper limb in stroke patients. So we set up a dedicated upper limb service. So we have an upper limb program now where we bring people in for 3 weeks intensive therapy in the arm, which is an unusual service. This service, as far as I'm aware, doesn't exist anywhere else in the UK. So it's based essentially on hands-on therapy. So patients will come in, as I said, for 3 weeks, and in a day, we're really aiming for 2 hours of physiotherapy, 2 hours of occupational therapy, although they may do joint sessions, and then between 2 and 4 hours of sessions, which might involve technology. So it might involve the use of robotic devices, but it might also involve patients doing exercises on their own, using low-tech solutions like the GRASS program, for example. But certainly, the way we see these technological solutions is, in a way, what we're trying to do is provide a more enriched environment for our patients. So a number of different ways that they can achieve some of the same goals.
Okay, yeah, sorry.
What I was going to say, what's really important, I think people can get the idea, particularly from the clinical trials that have been done, that the question is robotic devices versus conventional therapy. And clearly anybody who would use these devices in a rehabilitation setting would not see them in that way. These are things to be used together to complement one another.
Okay.
So a robotic device, for example, may give you the capacity to do mass practice, lots of repetitions. The therapist has the chance to select exactly and precisely the muscles that they want to work, the movements that they want to target, and after mass practice, the therapists are essentially going to take any benefits that they've made and try and turn these into functional gains in a real world setting. So these things need to be used together rather than to be pitted against each other, which is how they're looked at in clinical trials.
So the question is not either technology or no technology, it's more to combine conventional therapy with technology-related rehabilitation, and then to pick out really the benefits of the technologies to complement modern rehabilitation. Is this the main message?
I think so, and I think people, that therapists in particular, who work with some of these devices understand this intuitively. This is how they would think about using these devices. They would never think to use them one against the other. And I think it's the flexibility of some of these devices that allows you to target certain movements or certain tasks which the therapist knows can be turned into functional gains in other sessions that makes it valuable.
So to summarize this would mean that as a therapist, the art of the therapist is really to take out these benefits of a technology device and to implement it in the existing models or in the existing therapy.
But also, I mean, as you know, these devices are they're incredibly flexible. So the other skill that they need is to know how to use these devices. It's really not just a case of just strapping people in and then pressing go. There are all kinds of functions used in these devices, and a good and experienced therapist will know how to use them.
Okay, and what could be the future role of the rehab world? If you can give us an outlook in the next 20, 30 years, how should a modern arm rehabilitation look like? So do you have any suggestions? Do you have any tips for the other clinicians?
Well, I don't have any tips, that's for sure. I mean, I think that the way I think of, where is the future in terms of arm rehabilitation? I think the first thing that we have to acknowledge is that there's a difference between treating people in the early period, which we haven't properly defined yet, but certainly the first few weeks and maybe first few months, and treating people in the chronic phase. One thing that we haven't talked about that's absolutely crucial to good functional outcomes is avoiding complications in the upper limb. And I think this is something that we see a lot. We see a lot of people in clinic who maybe have got good, nice movements that we would like to work with, but they maybe have significant problems with the shoulder, very painful shoulder. This is something that needs to be dealt with first. So first of all, avoiding complications is critically important. We need to really understand this early period of the post-stroke brain, spontaneous biological recovery, because it's likely that the way we train people in that period is going to be different. It's probably not going to be about task repetition. We probably need to let people explore their capabilities more in order to be able to solve a wider range of problems. When this period has died down, if we find evidence that it does and people are in the chronic phase, then maybe we do think about targeting more task-specific training that can be turned into functional benefits. But I think we still don't know what the capabilities of training people in the chronic phase are, and I would say that that's still an open research question.
Okay. I also have a question from the audience. So Jose would like to know, when we talk about intensity, we always think about the numbers of hours. But what about the intensity of the exercise? So I think he's mentioned the difficulty level, the effort of the patient. How can we measure and adapt that aspect? What would you comment?
No, absolutely. I agree. You could spend within a 1 hour session, the patient may not be engaged at all. I mean, it's the difference between, rather than think about task-specific training, you can imagine somebody who has neuromuscular electrical stimulation, which is just moving the wrist back, but whilst it's doing that, they're watching television. It's not the same thing as being engaged with the movement. So it is critically important. I mean, I would add something else that, so the issue of dose has become quite topical. So, you know, when I say dose, I just mean more hours, more intensity, more involvement. I think we're not at the stage yet where we can worry too much about exactly what type of scheduling we do in upper limb rehab, because fiddling about with the scheduling of not very much is not going to make very much difference. We really, first of all, need to work out ways of just giving more, and that's more of everything: more time, more intensity, more motivation.
Okay, so the complete dose. It's not only the hours; it's the complete dose. But at the moment, the complete dose or the volume is at too low, too little. Therefore, we have to work on several aspects in the future. Right?
Exactly. We're still basically at the starting gate with working out how much we should give. And the answer is whatever we're giving now, we should be doing more. When we know that a big dose has a big effect size, and we've demonstrated that, we've convinced the world, then we can start to worry about the scheduling of it.
Okay, there's another question from Antonia. There's more and more research on the positive influence on dopaminergic system in motor learning. Do you think new technologies can have an advantage here over conventional therapy? So
you mean in terms of interacting with the dopaminergic system?
Exactly, or to influence this in a positive way to get, I think the question is related that maybe the new technologies can have a more influence on the dopaminergic system rather than conventional therapy.
Yeah, they might do, but I mean, I would still put that in the category of things to be worked out in future, when the big glaring question is we're just not doing enough. The other way of looking at it is, don't forget that if some of these technologies are not used in the right way and patients find it particularly frustrating, they're not going to find it particularly motivating. So I come back to the point that these are complex tools that need to be used by skilled operators, skilled therapists. Otherwise, it could have the opposite effect.
I agree. And that's, again, you're talking about the motivational aspect, also the enriched environment you already mentioned, right? That's
absolutely. Those things are important.
Okay, thanks. Thanks for your input, Nick. It was really a pleasure to have you here in the webinar. Hope you have a good day in the UK. Thanks for your time, and bye-bye and see you.
Bye-bye. Thank you.
Before I introduce our second guest speaker, Stephanie Salentine, I would like to show you a short video about her workplace. The Marianjoy Rehabilitation Hospital is located in Wheaton, Illinois, and offers 100 acute inpatient rehabilitation beds and 27 Medicare licensed subacute beds for adult and pediatric patients recovery from illness or injury who required intensive therapy to regain their functions and independence. Patients are treated by specialized trained therapists and clinicians using the latest and most advanced rehabilitation technology available. Stephanie will be also available to answer questions directly, so please take the chance to send your questions through the chat function. Stephanie is a clinical development coordinator at Marianjoy Rehabilitation Hospital. Hi, Stephanie. Hope you're doing well. Can you hear me?
I can.
Hi. As we have seen in the short video, your clinic is using technology for arm rehabilitation. What kind of pathologies do you treat?
Sure. At Marianjoy Rehabilitation Hospital, we use the DME Power and the DME Spring primarily to treat our neurologically impaired patients who have limitations with their upper extremity, and we're currently increasing our use with our orthopedic population as well.
Oh, that's great to know. Where do you see as a clinician the benefits of such devices? So we saw the DME Spring in the video, and the patient was really engaged. So what's, from clinician point of view, from your perspective, where do you see the benefits of such an Armeo spring device?
Sure. I think there's a multitude of benefits for our patients. I think that first and foremost, the Armeo Power allows us to treat within the body of evidence that suggests that priming and mass repetition along with a task-specific approach is most optimal for our patients. So it allows us to treat the most severely impaired patient within what the evidence suggests as occupational therapists we need to do in order to most optimally treat our patients.
For the audience, maybe the Armeo Power is a robotic device with needed support to conduct the movement. Okay.
It is, absolutely. So it's a robotic exoskeleton.
Okay.
And for the Armeo spring, the benefits of coupling traditional intervention and traditional treatment with a spring-loaded device or a robotic exoskeleton only enhances our ability to provide that optimal treatment session for our patients every time.
Okay. And could you also give us a little insight into your clinical routine? So what is typically the progression of a patient using such a technologies? How do they react? How do they feel? What do you see in terms of outcomes? What's your experience?
Sure, absolutely. So first and foremost, we comprehensively evaluate the patient. So we take note of their abilities, we take note of their limitations, and then we funnel the patient through to either the Armeo Power, which is the robotic exoskeleton, or the Armeo spring, taking into consideration the inclusion and the exclusion criteria that were set for each patient. We then visually observe if the specific robotic or spring-loaded intervention is appropriate for the patient and adjust and modify in order to meet the needs to create a just right fit for every single patient that we treat. After a comprehensive evaluation and subsequent intervention, we then take note of any progress. I think the outcomes that we are seeing are absolutely amazing. They're energizing for our therapists. Yeah. It's energizing for our patients. When it's delightful when you start to use the technology that we have at Marianjoy and you see a patient's face light up, because this technology allows them to move their upper extremity in a way that they would not be able to independently move themselves. Okay. Coupled with the success that they feel using the visual feedback with the applications that are available with the spring and the power, there's a certain amount of success that the patient is able to experience because of the movement coupled with the applications and the gaming.
Okay, and I've also mentioned at the beginning of this webinar that, and you also said that the needs of a patient is really important to cover the needs of the patient. And we also know that each patient is slightly different. So, and also if you have a progression during the rehabilitation, is it also possible to adjust the technology or the device to increase the challenge aspect of the patient or to shape a little bit more? What is your experience? How do you proceed with the progression of a patient?
Absolutely. Yeah, that's a great question. So there are multiple variables that you can modify in order to set up the most optimal situation for the patient with both devices. For the Armeo Power, there's a certain percentage of arm weight support that you can either increase or decrease. For the visual feedback, for some of the software that you receive with both of the Armeo devices, you can increase or decrease the visual challenge within that application. So yes, and there's other variables as well that allow the therapist to modify the intervention being provided by the therapist coupled with the technology or the spring-loaded device in order to meet most optimally actually meet the needs of the patient.
Okay. Do you also see the transfer of the rehabilitation or the treatment into the ADL scenario. So is it possible for you to treat patients and then to do a transfer in real life? Does this help you?
Sure, absolutely. Along with clinical integration of these pieces, because I think that therapists, so we went to school and we got a degree and we received all this didactic information. And because this technology is so new, our curriculums didn't necessarily include how to use this. But what we've done at Marianjoy is we've created a standardized process in order to be able to prime the patient, complete mass repetition, and then transition over to a functional space, and may that be a kitchen or a bedroom, in order to be able to link the mass repetition or the priming to an actual functional task, because that's what's important to our patients, is to regain function. So we are able to successfully use our technology and then integrate that into daily living tasks, meaningful, purposeful things for the patient.
Okay, we also have a question from Jose. He wants to know, most of the robotic devices have a focus on shoulder, elbow. What about the hand? What's your experience and present evidence in relation to regaining the hand function?
Absolutely, that's a great question. So with both the power and the spring, there is a hand piece that's available. And so we received the handpiece along with our purchase of both of the devices. So and some of the applications or the gaming devices actually focus on grasp and release.
Yeah, okay. So you would agree that the hand function is also a very important part, which should be more focused also on rehabilitation, like I think Jose would like to mention in his comment or question.
Oh, absolutely. So when we talk about the body having proximal versus distal function, so having shoulder and upper arm function, and then moving that down through the continuum to the forearm and the hand, making sure that the therapist has an eye on what neuromuscular return is available, and then being able to integrate that into your functional task, because you are able to address it with the Armeo Power and the Armeo Spring. And so, to your point, being able to integrate that into the functional task after you prime the patient and complete your mass repetition with the robotics is extremely important in any kind of recovery.
Okay, we have an additional question from Sandra. How do you decide who to treat with the Armeo? What are the inclusion criteria or contraindications? So could you give us an insight?
Absolutely. So when we received both devices, we received them and received formalized training from Hocoma. That formalized training included a series of can I call them risk factors or contraindications for use with the device? So we do adhere to those contraindications, and the therapists, we have a super user group that is designated within the Marianjoy network, and the super user group created a series of inclusion criteria, and then Hocoma's contraindications served as our exclusion criteria.
Okay, good. We have an additional question from Renato. Is the patient's age relevant when deciding whether to use robotic technology, and how does it affect the outcome of the therapy?
Well, I think that a patient's age is pertinent. It's a pertinent fact due to the size of the power and the spring. Okay. So the spring has a pediatric version, and the spring also has an adult version. We have the adult version. So currently at Marianjoy, we are using the power and the spring only for adult purposes.
Okay, but at the end,
due to sizing.
So, but at the end, as if I get it correctly, it's not mattering the age; it's more the size of the upper and lower arm, if it fits or not fits, right?
I think so. I think that the size is more pertinent than the age, absolutely.
Could you also give us some input about the limitations of technology in general, also the limitations of Armeo? So you mentioned the device is really brilliant, you have several options, and it fits also to your principles of rehabilitation. But are there also some limitations for you as a clinicians? Is there something that would you say, there's space for improvements?
Sure. I think that's a great question. Taking a look at the big picture, I think as with any technology, there is a learning curve. There's a learning curve to use. A therapist and a clinician requires time in order to be able to be proficient with the technology. So that's what I mean by terms of learning curve. I think, though, if you choose a very high-performing and intrinsically motivated super user group, that proficiency is gained very quickly. That learning curve, that the time that it takes to set a patient up and get used to the variables that a clinician can modify in order to achieve that just right fit or that optimal treatment session, I have to say the super user group at Marianjoy picked up so quickly and was able to move through that curve so quickly because they were so motivated. They saw what they could do with the patients and the response of the patients. And the clinical integration piece, I couldn't be happier with it. It was just so quickly adopted into our bag of tricks or our tool bag as a clinician.
So it's similar, like the statement of Nick Ward. He also mentioned that with all technologies, it's not only pushing a button to start and to stop. You also need to know how to apply and to integrate the device as most efficient as possible. But at least the tools are existing to do this. And as you mentioned, with this super user group, if you are really into it and if you really practice and if you use the device, it's easy to get to this level. Is it correct like this?
Absolutely, that is very accurate to say. And I think as well, the technology, so the software that's available that comes with the Armeo is user-friendly. So I think it lends itself to a quick understanding and ease of use.
Okay. We have an additional question. It's from Eddie. Any experience with pediatric rehabilitation, particular children with cerebral palsy? And if so, what are the outcomes? So I know you have already mentioned you're not using the Armeo Spring with pediatrics. Is this correct? Or do you also have some experience with a little bit, let's say, a bigger child using with the Armeo Spring?
We don't have any experience right now. That is in our future plans. We do at Marianjoy treat the pediatric population, and we have been running some constraint-induced movement therapy groups in order to most optimally treat that patient population. But we currently are not using the Armeo Spring or Power within a pediatric population.
Okay, but maybe a comment from my side to Eddie. Yes, there are some a lot of clinics using the Armeo Spring with CP patients, and I can strongly recommend the knowledge platform of Hocoma, where you can find clinical research parts and also clinical experience parts, and maybe you can have a quick look, and maybe this could answer your question. So Stephanie, thank you very much for your time. It was really a pleasure to have you here in this webinar. Thanks for your insights and your feedback, and we really appreciate it. Have a good day. I think it's in the morning in Illinois, so have a good day, and thanks for your time. Bye-bye, and hopefully see you soon.
Okay, thank you.
Bye-bye. So it seems that existing models of care do not provide sufficient levels of therapeutic intensity to promote motor recovery after neurological impairments such as stroke. Given the organizational limitations in the healthcare sector, advanced technology such as the Armeo Spring, can help overcome these limitations and dramatically improve motor recovery after neurological impairments. As we have heard, the Armeo Spring features a spring-loaded exoskeleton which support the patient execute functional and physiological arm movements. This allows patient to perform arm and hand movements with a high number of repetitions, even if they are not able to entirely support the weight of the arm. Furthermore, you can adjust the arm weight support to increase or decrease the challenge, a simple way to guarantee an optimally intensive training session beyond the present technological capabilities. The Armeo Spring also offers software with a wide range of motivational exercises that are based on ADL movements. Video, please. The exercises and the three-dimensional workspace in which the patient trains can be adjusted to shape the challenge aspect. For example, you can select a specific movement task you want your patients to train, or you can adjust the difficulty level and the visual detail of the exercises. Changing the difficulty level generally changes the level of motor control the patient must have to successfully do the exercise, or changes the task complexity, like including additional obstacles, or changes sizes and speed of the objects. Adjusting the visual detail changes the appearance of the background and other visual elements, thereby challenging the patient cognitively as he or she does the exercises. Furthermore, the software gives you an immediate feedback for you as a therapist about the performance of your patient after session, as well as a feedback for the patient about his or her progression over multiple sessions. Thanks to easy handling, quick setup, and patient guidance through intuitive software, clinicians can maximize the volume of intensive therapy through self-directed training and group settings. Additionally, in one Armeo Spring development project at the moment, we are interested in increasing the intensity through extra time training. The goal is to adjust the hard and software in a way to use the technology also for after hours or weekend treatments with limited supervision. Furthermore, the Armeo Spring offers synergies which could be also used with conventional therapies, thereby presenting a solution to integrate technologies like the Armeo Spring as a concept in the rehabilitation routine to optimize the transfer back to daily living situations. So, to recap, with the Armeo Spring, you can provide intensive therapy with a high amount of repetitions in line with motor learning principles, individualized therapy according to the needs and goals of your patients, with one single tool, customize the training according to capability, timing aspects, and functional limitations through easy adjustments in hard and software. And finally, Armeo Spring provides an efficient therapy setting to overcome the challenge of increased patient numbers. If you want to have more information about modern arm rehabilitation with the Armeo Spring, either visit our website at hocoma.com or send me an email directly at clemensmüller@hocoma.com. For the next exclusive webinar, the topic will be how can advanced technology enable safe and early mobilization. Thanks very much for watching, and now I'd like to open it up for a question and answer session. So we have a first question from Aguero. Motivation versus distraction. The use of sophisticated graphical user interfaces and scenarios could lead patients to lose focus on their given tasks. How do you think technology should address this issue? So I completely agree to your statement and also to your questions. So the visual complexity is definitely an important point we have to focus on with the virtual reality. The good thing with this Armeo Spring is that you easily can adjust the visual detail for each exercise. So you can reduce really the distracting situations. So according to your patient's ability, cognitive ability, you can adjust the exercises and the whole scenario to challenge the patient more, on the one side to give him more motivation, but on the other side also to keep the distraction on a level you would like to have. An additional question from Michael. How do you handle the treatment with isolated patients? Access to robotics, not at all. Treatment at the patient room. I think that's definitely an important point, and so far it's also quite difficult because with technology it's also let's say an issue with the space you would need to work with the patient, and with isolated patient and to transfer the devices from one room to the other. That's an important point. It is possible with current technologies, but at least there's a lot of space to improvements. But I also think in general technology, which also includes, into my term, also the sensor-based let's say the sensor-based technology, that could be also a solution. So that's more easy to transport the devices. So maybe also to include sensor-based technologies into the whole environment could help. The next question is from Belen. Do you have any limitations if the patient has a neglect or cognitive impairments? If a patient is not able to follow the task or which is given on the virtual reality on the software, then of course it's quite difficult. So far we have a research project on neglect exercises, and maybe we will come up, and I think that's also a big improvement or a big important topic of the Ameo Spring, that there will be constantly an improvement of the exercises with new exercises for the customers. It is an important topic, the cognitive impairments, but as I mentioned before, for cognitive impairments, you easily can adjust certain level of visual details. We have 3 parts. It's the low level of visual detail, the medium, and the high level, and so you can choose. There's a question from Sandra. Can I use the Ameo on both arms, or do I need 2 different devices? That's a really good question, Sandra. So, with the Ameo, you can easily switch from left to right side. So, it takes you around 10 to 15 seconds, and I'm pretty sure Stephanie from Marianjoy would also agree with this. So it is possible to treat patients as on the left as well as on the right side, but it is not possible to do this treatment at the same time. So you have to focus either on left and right side, but with easy handling, that's definitely possible. There is a question from Maria. Comment to Michael. In Norway, they have used the Ameo Spring for isolated patients. Very motivating for the patients. Thanks for this comment, Maria. So I think there are some examples all over the world where it is possible and where they do this. But at least I think also that's the goal of a medtech company, to constantly improve the devices in terms of the application. And therefore, I think that's still a topic we could address. Are there any further questions? Yeah, I have a question from the admin. Yes? Okay, how do we ensure, so it's a question for, okay, it's, okay. How we do ensure the good application? So I think Stephanie already mentioned this. As she said, somebody's coming to the clinic and showing the setup and the device and explaining everything. So the company included in the product is also a half-a-day training, where all the therapists will be educated and trained on a good application with the device to ensure an effective, efficient, and safe use. So that's definitely one of the major goals, so that the end customer is able to use the device perfectly. Any further questions from the audience? If there are no further questions, I would like to thank you for your time to join the first Hocoma Academy webinar. I'm really looking forward to meet you all for the next webinar in a couple of weeks. You will also receive an invitation. Thanks for your time and have a good day. Bye-bye.